Hello, everyone. Thank you for attending. This is our first webinar in a new series, weekly series that we're doing, and we're very, very excited to have Sierra Jones from Hospice with us. And we're going over what I think is a really important topic because so many people approach us scared of hospice. And hospice is not something to be scared about. So I'm really excited that Sierra is here to go through exactly what hospice is and what is covered under hospice. Just to tell you a little bit about who I am the CEO of Just Us Retirement Solutions. We are a full retirement company, and we have what's considered a collaborative and an education focused approach. So what that means is we partner with a lot of different companies to provide education, which is exactly what we're doing with Sierra and Hospice today. We are also doing this in collaboration with Bringing Back the Village. It is an umbrella organization that brings profit, nonprofit, private businesses, government businesses all together so that we can eliminate the complexity that a lot of people face when they're trying to receive care as they age. So, Sierra, I'm going to let you introduce yourself.
Absolutely. Hey everyone, I'm Sierra Jones. I am the liaison for Canal Hospice Care. I have been with Hospice Care since May of 2018, so around 6 years. I have worked as a nurse in the field with hospice care. Initially, that's where I started. So I would go to patient homes and see patients in their home and care for them throughout their hospice process. I later worked at our inpatient Hubbard House units. We do have 3 local inpatient units here in Charleston. And I later became the liaison for our palliative program and now have transitioned as of this past January to liaison of our entire organization, which encompasses hospice care, palliative care, and our new home health company. So very exciting to be able to be the person in this position.
Wonderful. Thanks, Sierra. And let's kind of quickly set the tone for everyone because we really do have 2 goals from these webinars that we're going to do. Of course, we want everyone watching this for self-education. We want you guys to feel empowered to understand your options so that you can make the best options for you. But really, almost just as important is we want you to understand it so you can help other people. A lot of times when things come up and we need help, we are personally too overwhelmed with what's going on, which I'm sure you see a lot, Sierra. It's just for the family, it's a lot of emotion. When we have friends and family that are able to stay a little bit more calm during the process, but they have education that they can share, it makes a world of difference. And so that's one of the things that we want to do with this. We want you to take what you're learning today and share it. Share the information, have simple conversations with people in your life about what you learn. And together, we will be able to create a kinder, healthier, and stronger community. So that's the goal with these. I'm going to slide through these, and then as we need to go to the next slide, just let me know, Sierra.
Okay.
But could you teach me why hospice?
So hospice care is for patients who have been given a prognosis of less than 6 months or less to live. And that's if the physician says, I wouldn't be surprised if all care was stopped, this patient would pass away within 6 months. So that's where hospice comes in. So with hospice care, we are, Canal Hospice Care is the largest in West Virginia with over 40 years of experience. And we currently service 16 counties with our hospice services. So we are very large in the area, and we are also ranked among the top in the nation, which is huge.
Yeah.
And, that's all thanks to all of our staff. But why hospice? Everyone is going to eventually need hospice, right? So just as we come into this world, there is a time where we have to leave. So hospice is important to find comfort and dignity and peace surrounding that time in your life. So it can be very scary, but hospice care takes all the fear away. So we want to provide that comfort and give patients quality of life at the end. So that's why I would say, why hospice? Because if it's your time, why not be comfortable and feel respected and given dignity that you deserve?
I love that. That's a great way of explaining it. So first we are going to talk about what hospice care, and later we're going to transition to palliative care. So we're going to explain the differences with hospice first.
Absolutely. And I love that you said explain the difference of hospice first, because a lot of times people think that when they hear the word palliative care, that means hospice. And so they are completely different programs. So we will start with hospice care. So, like I mentioned a moment ago, hospice care focuses on comfort. So when you are nearing end of life, we focus on the comfort of the patient and compassionate care to the patient and the family. So at some point, your physician may say, maybe you're seeking treatment and the treatment is no longer working, or it's no longer effective, or it no longer aligns with the goals that you have set. So that's when you may decide hospice is right for me. So when given the diagnosis of 6 months or less to live, you sign up with hospice care. But what happens if you surpass that 6 months? So just because someone signs up under the care of hospice doesn't mean that they have to pass away within 6 months. So if you surpass that 6 months and you remain hospice appropriate, then we continue services with you. We've had patients for a year and more, and we've had patients for less than 6 months. So it can go both ways. So sometimes patients can be referred too late and they're only on services for days. And I want to just touch that a common myth about hospice is that as soon as you go on hospice services, you're going to pass away within days. And that is so far from the truth if referred appropriately. So patients who are already actively dying and then referred to hospice, of course, those are patients that were referred late and likely will pass within a few days to weeks. But for the most part, we actually want patients for that full 6 months so we can show them the comfort, the peace, the dignity that they deserve, and to give their family that additional support that is also deserved while going through this process.
Yeah, one of the reasons actually why I wanted you to come on was that myth that you just talked about.
Mm-hmm.
From my end, I have referred a lot of people to you guys, and you talk about the importance of proper referral. A lot of times I've noticed I can refer someone to maybe talk to their doctor about it. And I imagine the doctor has the same response that sometimes my clients do of, oh no, we don't want to go to hospice.
Mm-hmm.
Hospice is scary, or that's only for the last couple hours or days. So I'm really glad that you emphasize that, because hopefully with this education, people will seek it out earlier because they'll understand that's not how hospice is supposed to work.
Mm-hmm. Yes.
Okay, so hospice services, would you like to go over those?
Absolutely. So what is involved when you say, okay, I'm ready to sign up for hospice? So we offer the most commonly known pain management. It's a comprehensive pain and symptom management. So we have a medical director who oversees pain management and symptom management who is specialized in end of life. So I like to emphasize on specializes because hospice care is a specialty, just as cardiology, pulmonology, oncology. Hospice care is also a specialty. So when you are nearing end of life and you are having pain from the end of life symptoms, it does require a specialty, which falls under the umbrella of hospice care. So when you're on services, you will have availability to nurses 24/7. So that doesn't mean that someone's going to be in your home 24/7. That means you have access to contact someone to come and see you at all hours of the day or night. So typically on hospice services, patients are seen by a nurse. It could range from one time a week if they have been on services for a while and they're stable, to every day of the week if needed, if they're having some symptoms or some pain. So visits through the week vary depending on a patient, but you do have access to our services 24/7, and a nurse can come out at 3 a.m. if that's what you need. We also have certified nursing assistants, which are fantastic. I always say they are the backbone to our company, because these are the people who are out there bathing and dressing and changing the linens on the bed sheets. The patients' families are caring for these patients every single day, 24/7. They don't get a break. So our certified nursing assistants are the ones who go in there and give that patient dignity, get them cleaned up, and get them feeling good about themselves. So I just like to always say that they are our backbone of our company. And then we offer support for the family and or caregivers. So the support comes from everyone involved. So you will get support from your nurse, from the CNA, the social worker, and from our bereavement team. So we have a robust support system for the patient, the family, and the caregivers. And then we also have volunteers who are merely volunteers to us. They are unpaid people who find a purpose to volunteer with hospice. These volunteers can do anything they can imagine they would like to do, from licking envelopes to making copies to being hands-on with the patient, sit with the patient and hold their hand, sit with the caregiver or the patient while the caregiver goes out to run an errand. A lot of our volunteers pick up medications at the pharmacy and deliver it to the patient. They can read to the patient. They can pray with the patient. They really can do whatever they choose to do and whatever the patient needs. And then, of course, we have spiritual support from our chaplains, who are absolutely amazing. We have a super robust spiritual team that goes out to see patients when requested or needed.
I know when my family, we used hospice on a loved one, and for the family, it was really nice because the spouse of the person that was passing away was one of those, oh, my house has to be clean. It has to be presented. I have to, and that's what her mind was focused
Mm-hmm.
on. But the CNA assistants, when they came out, they were like, no, you sit with him. We will
Mm-hmm.
take care of the rest.
Mm-hmm.
And I knew for my family how big that was, because that is what she wanted to do, is just sit with her loved one. And so
Yes.
that was a beautiful moment.
Yeah, absolutely. And that's what I tell people all the time, because that's a huge, that's a common concern. Oh my gosh, my house is a mess. I can't have anyone in my house. And I always encourage people. I was a field hospice nurse for many years, and we don't look at your house. Um, I honestly can't say I even saw the dirty clothes in the floor. I didn't see the dishes in your sink. I was there to care for the patient and the family. I didn't see the flaws that the family was worried about. So I always encourage people, don't be worried about that. And most times we'll pitch in and say, what can we do to help while we're here? So
Yeah, that was very much the experience that I had.
I'm glad.
Okay, bereavement services. This is the tough one.
It is a tough one, but it's an exciting one at the same time, only because our bereavement team is so robust. So our bereavement team starts from day one. So when a patient is given a diagnosis of 6 months or less to live, that in itself is so hard to understand and to comprehend. So bereavement is there to just help you in that spiritually and emotionally. And it's for everyone involved. This is for the family, the patient, the caregivers. So it's not limited to just the patient. So the chaplains are chaplains that go in the home. So you don't have to go out to an appointment to seek this. They come to you at your bedside, and It can vary depending on patient needs, but they can come a scheduled amount of time. You can call them just when you feel like you need them, but they are there for you during your entire hospice process. You're not required to have them if it's not something that aligns with your goals, but they are available and they are fantastic. Another great thing about our bereavement program is we offer bereavement to patients' families and loved ones for at least 12 months after that patient passes away. And for me, that's like one of my biggest talking points because that's amazing. I don't know if you've ever been to counseling and know how expensive that is just in itself. So our bereavement team is there for that family, no matter if the patient had us for 1 day or 2 years, they equally get that service and they don't have to give proof of how they're related. It can be the neighbor that was affected. It can be the sister that was affected. So it's just, when I say loved ones, I really mean whoever loved that patient and who it affected is who those bereavement services are there for at least 12 months after death. And those can be provided in the form of a phone call, if that's what the patient's loved ones want, or we have individual counseling. They can call our office and set up individual setting, meetings, or it can be in a group. Some people find group settings to be helpful because it's full of other people grieving. And so they can find comfort and support in like-minded people who are going through the same thing they are. So.
And this goes back to the importance of trying to get that 6-month referral because it's preparing you for the grieving process instead of, I know a lot of people try to ignore that step until it's overwhelming.
Absolutely. Yeah. And so to have the bereavement services from day one of hospice, and we hope to have patients for 6 months or more, we want, surveys have shown that patients who are on hospice care longer have a better experience. And why is that? It's because they get to know us. They get to know our services. So, and they are prepared and planned, and it, like you said, it is better to go ahead and prepare for all of this and to have these sessions throughout instead of boom.
Yeah. I love that. And you're right. Like I thought of it as a tough subject, but it really is more of a beautiful subject.
It is. Yeah. It's one of my biggest talking points is our bereavement program.
So tell us about how inpatient units work.
Absolutely. So like I said in the beginning, I also worked at our inpatient units as a nurse, and I loved every minute of it. So the inpatient units can be used in a variety of different ways. So most of our hospice patients are home. So most of the times our patients are cared for in the comfort of their own home. However, some patients may need to go to our inpatient unit for symptom management. So maybe we've had them on service and their pain is uncontrolled, and the nurse and the physician are working to control that pain, but it's just for some reason not working. So we can send the patient to the inpatient unit for 24/7 care for a nurse and a doctor to really manage that pain and see what regimen is effective. Once we can get that pain under control with a medication regimen, then we can send them back home on that medication regimen. And hopefully that was a fix. Our inpatient is also used for respite. This is huge. Another big talking point for me with hospice, because respite care is provided to patients. So they have every 30 days, they get 5 days they can stay at our inpatient unit. I call this like a vacation for the patient and the caregiver or the family member, because like I said earlier, being a caregiver is 24/7. You don't get a break most of the time. So this is a safe place for the patients to go for 5 days. or less. If they didn't want to use the whole 5 days, they wouldn't have to. But every 30 days, they have access to that week of respite care. So while they're on respite care, they're in our facility. The nurse takes care of them just as their loved one would. They get their medications just the same. They have an aide there that can bath them every day. They get their meals. So sometimes it's literally a vacation for both the patient and the family member. So
I have referred many families to you guys for respite care.
yeah.
They're always shocked because they didn't know
Mm-hmm.
that this existed, and they're so thankful afterwards. And a lot of times they use that respite time just to sleep,
Yeah,
relax, build their energy back.
absolutely. Absolutely. And run errands or just get things done. Yeah.
Yeah, I love that service. So let's talk about how admissions work.
Okay, so with hospice care, like I had said earlier, so a physician would need to say that you have a terminal illness and that you would have 6 months or less to live if all treatment was stopped. So that's how you get into hospice. So that doesn't mean that you have to initially have a physician's order. So patients can call hospice themselves. Family members can call us and say, hey, I would like a referral to hospice. I think I'm ready for that. At that point, our intake would call the primary care provider of the patient and repeat what was requested and get an order. So that doctor would then say, okay, I agree with this. I do believe that if all care was stopped, the patient would likely pass within 6 months. And then we could proceed with hospice services.
Okay.
So with the inpatient hospice, that is typically for uncontrolled symptoms. So this can be from the hospital. A lot of times we get a patient who maybe they were doing okay and they had an acute event that landed them in the hospital, and then things took a turn for the worse.
Mhm.
And the doctors at the hospital say, there's nothing else we can do for you. We think that you're ready for hospice care. A lot of times these patients are so sick and ill, they may not be appropriate to go home with hospice because there may only be days. So that's a lot of times when an inpatient admission directly from the hospital would be appropriate. And then, of course, respite admissions. So those are for home patients who are on hospice services who the family needs a little bit of a break, and they can use 1 to 5 days every 30 days to get that break.
And we have coming up another session, and we're specifically talking about caring for the caregiver. And I just want to emphasize how important it is if people are caregiving. It is important for them to take care for themselves and use services like respite. It's
Absolutely. Yeah, working with hospice for as long as I have, so many family members are reluctant to use the respite at first because they feel guilty.
yes,
Think, oh my gosh, I can't. It's not even an admitting thing. It's just they feel guilty to say, yes, I need a break, or yes, I'm overwhelmed, or yes, I could use some sleep. So they do feel guilty to use that. But caring for the caregiver, so when they care for themselves, they can care better for the patient.
yes,
So it's very important.
yeah, I agree. All right, hospice frequently asked questions.
Absolutely. This is a big one for me. So this kind of goes back to what we discussed earlier. There's a lot of myths around hospice. So one of the big things that I hear in the community when I'm out doing events is, well, when they sign you up for hospice, they take all your medications away. And I love to get to educate about this, because hospice care, what happens when you get on hospice care services, we have an excellent pharmacist that works for us along with our medical director, and they review the medications you're currently on. So they do a medication reconciliation just to say, like, well, maybe you don't really need all of these vitamins anymore. But we do not take away patients' medications. Patients are still allowed to take all of their daily medications as long as they are able to safely swallow. So this does not include curative medication. So if it's a chemo pill, that wouldn't be allowed, because with hospice care, you're no longer allowed to seek curative treatment such as chemotherapy, dialysis, and things like that. So as long as the medication is something that you can safely swallow, we absolutely want you to still take that. There are cases where patients, if they aren't able to wake up enough to be alert, at that point, it's not safe to force that medication to that patient. So as long as they are able to swallow and understand the concept of swallowing the medication, absolutely, that's what we want. So when a patient becomes unable to swallow due to decline, maybe they are no longer coherent. Maybe they're just sleeping 24/7. Maybe they just have an issue with swallowing. A lot of dementia patients sometimes have this issue.
Mm-hmm.
So at that point, like I had said a minute ago, it's unsafe for that patient to be given this pill and said, here, swallow this, because they're going to aspirate on that and choke, and we don't want that. So if that becomes an issue, a lot of dementia patients, we can begin crushing medications that are able to be crushed, or we can move to liquid medications or comfort only medications. So this would be like stopping your blood pressure pill, because what good is it doing at this point? So we will wean patients from all of their medications when they get to a point of decline that the medications are no longer serving their purpose. So
I'm glad you went over that one, because that's another one of those.
It's huge. Yes. I always tell people, they're like, we get stories,
Yeah.
Well, they took my dad's medication away and he died one day later. And so I explain, we didn't take it away because we didn't have it. It's just a safety thing.
Yeah. So, but you guys, do you prescribe medication?
We do, absolutely. So like I had said earlier, we do have a pharmacist and our medical director. So we do prescribe medications. Once on hospice services, patients say, what will I do now? My primary care provider prescribes all these medications. We take over. So our hospice medical director will continue to refill all your daily prescriptions, aside from the curative medications, as I spoke to earlier. And each patient's medications will be reviewed in detail. So if it's considered a curative medication, the patient will be told that prior to admission of hospice services. So it wouldn't be a surprise to the patient that a certain medication would be considered curative. So we absolutely do prescribe all your refills. And then a lot of times, just because you have a diagnosis of 6 months or less to live, that doesn't take away the fact that you might still get the flu or an upper respiratory infection or a urinary tract infection or COVID. So we also will prescribe medications for those. And then, of course, the main medications that a lot of hospice patients are on are for pain, anxiety, and shortness of breath, depression. So typically anxiety and depression comes with a diagnosis. So we immediately address that need and make sure the patient is on appropriate medication for that, and for pain, obviously. So
Yes, you're smashing so many myths here.
Yes, I love it.
Okay, so this is another one. Does hospice speed up the dying process?
This is another myth. So a lot of people do think that hospice care speeds up the dying process, and that is absolutely so false. Hospice neither hastens or slows down the dying process. So we can't speed it up and we can't slow it down. The body is working, and we can't tell it what to do. We don't give medications to make the process faster. So the medications that are prescribed are based on the patient's symptoms. So we focus on symptom management with hospice. So we're not going to start morphine on a patient that doesn't have symptoms that say they need that. Okay, so that is a big myth. So in the second bullet, it says comfort medications such as morphine and Ativan are given as the patient presents symptoms. So this is pain, shortness of breath, restlessness. That's when we're going to look at the Ativan, the morphine, and they're given in doses that match up to the patient's weight. Okay, so a lot of times people get scared when we say, we're going to bring in some morphine for you. Yeah. And I tell people, as a nurse in administering this myself, the dose is so tiny. It's sublingual, which means it goes under your tongue or it can go in your cheek. It's such a small amount that you don't even swallow it. It actually just absorbs. So I always tell people that just to give them an idea of how small the dose is. Now, of course, the dose can be increased if it's not effective. So we may have to give it more frequently or increase the dose if it's not effective, but we don't give it to put the patient out. We give it just to manage that symptom of pain, of restlessness, of shortness of breath. And underneath there, I put this, there is actually no evidence that opioids such as morphine hasten the dying process. So that's super huge. So a patient that receives morphine versus a patient that does not receive morphine, neither patient is typically going to live longer. If anything, the patient that received the morphine passes away more peacefully because they're not in that agonizing pain. Yeah. So the difference in a study that I read is sometimes hours of a difference. So.
Yeah, I'm glad so much good stuff here.
Yes.
Here's another myth.
Yes, I'm all about myths on my PowerPoint. So does hospice allow patients to eat and drink? Absolutely, as long as it is safe. So we would never deny a patient of food or water unless it was a safety hazard. So a patient who is sleeping, maybe they're in the phase of the dying process where they go into this stage where they're sleeping most of the time. At that point, the patient's not waking up and asking for food or water. So a lot of times the families have difficulty understanding and grasping this because they say, well, mom needs to eat. She hasn't eaten all day. And they're trying to wake the patient up and they're not waking up enough to be coherent to understand simple commands such as take a bite, swallow. At that point, we just withhold or we encourage the family, don't force it. So we absolutely don't refuse food or water. I always like to use an analogy that I kind of created in my own mind. And it's, if you're sleeping and someone goes, oh, Tabitha looks so thirsty lying there, and I were to give you a drink of water, you would choke on that because you weren't awake enough to understand that I was giving you water and you're supposed to swallow that. So you're typically going to choke and aspirate on that. So I tell people it's not cruel to withhold if the patient is not alert or awake enough to understand it's time to eat or it's time to drink. Secondly, as patients progress into the dying process, they lose their ability to swallow. So this is something that does happen with all patients at end of life. And at this point, we're talking end of days. So the patient's unable to arouse enough to open their mouth, chew, and take those simple commands. So at that point, we do encourage the family not to force it. But however, we do tell the family at the same time, this is your loved one, so you know what's best. But we want to prevent aspiration as absolutely much as possible because that would just cause the patient to suffer.
Right. Okay. This is a good one. How often does hospice visit? You kind of went over this earlier.
I did touch on this. So it's a commonly asked question. So a lot of times people think that when you get hospice, you get someone in there 24/7. And so that is not true. However, there's a nurse that visits regularly. So when I say regularly, when you're new to hospice, it's a few times a week. Maybe you can kind of stabilize a little bit here and there, and the visits can change. So each week is different. It depends on what the patient needs.
Okay.
If this week the patient's not doing well, they may need seen every day and even on the weekend. If they're doing well and they have no needs and they have all the medications, they may be able to only get a visit 2 times a week, 3 times a week. It's just so based on the patient.
Okay.
Along with that nurse visit, you'll have a social worker visiting, and then you'll have your CNA, who typically they visit 2 to 3 times a week to give the patient a bath or help with a shower if needed. So each patient is assigned a social worker, and that social worker, it says in here biweekly or weekly to biweekly. Sometimes it's more. Sometimes there are families that have a lot of social needs and need a lot of assistance. So sometimes the social worker will kind of buddy up with the nurse and go with that nurse each visit. So like I say, every patient is so different, but you will at least be seen a couple times a week. And then the next one here are chaplains. So chaplains are available to visit based upon request. So every patient isn't just pushed a chaplain. When the nurse and the social worker go in to visit the patient, that's something that's discussed. Would you like a chaplain? Is that something that aligns with your goals? And if it is, then we get that set up, and that chaplain reaches out to the patient themselves, and they figure out days and times of the week that work best. So chaplains might visit this patient more than they visit this patient. It just depends on what the patient's wishes are. And then also the volunteers, I spoke on them earlier. They also help visit the patient, whether the patient needs a break or the caregiver needs a break, or they need tidying up. The patient's lonely and needs somebody to read to them or just sit with them. So we do have volunteers that are so fantastic. We love our volunteers, and they help with this need as well.
I like one thing that you keep saying is according to the patient's goals. And I love that because, again, that's putting the patient forward, and people have this idea that hospice is just one path, but it's not. It's individualized to what they want to experience.
Absolutely.
Yeah, I love that. Okay, where can people receive hospice care?
So almost everywhere, which is crazy. A lot of people don't know that. So most of our patients are seen in the home. That's their preference. Like you had just said, it's what the patient wants. So if the patient wants hospice services in their home, that's where we're going to be. Some patients are in nursing homes. Just because you're in a nursing home or a skilled facility or a memory care unit, assisted living, personal care home, everyone has the availability to get hospice care if they want. So we have multiple patients in the local nursing homes and facilities. So just because a loved one is in a facility doesn't mean they can't have hospice services. We meet patients where they are. The only, I would say, part that's different is a hospital. So if a patient is in a hospital and they're still actively seeking treatment or testing, our assessment nurse would go and assess that patient, and then we would plan a discharge. And we would say, okay, where are we going to go? Are we going to go home? Are we going to a facility? And then we would provide care for the patient and where they discharge to. And then also, of course, at our inpatient units, we can provide hospice care.
Wonderful. And we get this one a lot too. Who pays for hospice?
This is so big. We get a shocking look every time we answer.
Yes.
And your insurance pays for hospice care. There is no out-of-pocket expense for hospice care. So it's covered by your Medicare, your Medicaid. There are some young people, unfortunately, that are on hospice services who maybe don't have Medicare, but they also don't have Medicaid because they work. So a private insurance company is also accepted. So insurance does cover hospice services, and it covers all that comes with it, the supplies that we bring to the home and the equipment.
And I could be wrong on this, but that includes respite care also, right?
Yes. Respite care for patients, like I said, it's Every 30 days, you get 5 days. Now, if a patient wants or needs more than that 5 days, then there would be a fee upon that. So there is that if they needed more than the 5 days. But something I didn't cover is if a patient goes to our inpatient facility for an acute need, such as pain management or symptom management, that's covered. That doesn't count towards respite. That's just additional that we send the patient to the inpatient unit to get those symptoms managed. They still have access to those 5 days of respite care, regardless of how long they're at our inpatient unit receiving that acute management.
So let's just recap for 1 second on this. What people should keep in mind is you can have the full 6 months. You're going to get personalized care. It's going to be around your goals, not what someone else tells you you should be doing. And there's no cost to the services if you're on Medicare or Medicaid.
Yes.
Like, that's really big.
It's huge. Yeah, it's huge.
Yeah. Palliative care. I love palliative care, so I'm really excited about this one. Okay, so what is it?
Yes, so palliative care, it's commonly mistaken for hospice care. And I want to just say that off the jump, that palliative care and hospice care are two totally separate programs. As I had mentioned in the beginning, I was strictly the palliative care liaison before taking the role of liaison of all. So I'm also very passionate about palliative care. And I do like to just reiterate that it is a different program. So palliative care is for patients who have a serious illness, but are still seeking curative treatment and are not eligible or do not want hospice services yet. So these patients are seeking all treatment. They're going to the oncologist. They're going to their specialists. And the palliative care team comes in as a resource to help navigate the healthcare system and provide support. So a lot of times you leave the oncology office and all you heard was you have cancer. Well, the doctor is talking after that and the nurse is giving you all this information and you're sent home with all the information about your treatment course and your options, but you can't understand it because you were just told that you have cancer. So I use that as an example because palliative care comes in and sits down with you. It's a nurse practitioner and helps you to understand your illness and your treatment options. So it's super huge. A lot of times I would get calls and say, no one told me I was dying. They sent a referral for palliative care, and I explained to them, your physician thought that you would benefit from additional services. So our palliative care center empowers patients to make decisions that meet their goals. So again, with our palliative care program, it's patient goal oriented. So we start the conversations and the patients drive that bus. We say, what do you want? What are your goals? And we help them to understand the treatment options and just to navigate to make sure that their goals are met.
Yeah, love that. Thank you. And now I'm saying it wrong. Palliative care in oranges?
Some people say palliative, some people say palliative. I don't think there's a wrong or right way to say it. So this is a cute little slide. Quality Insights actually came up with this, but it's a way for patients to understand, okay, so what does palliative do? Because sometimes they still can't understand. So what are you going to do? So palliative care, so say you have congestive heart failure. That's like having one orange in your hand.
Okay.
Well, then they say now you're a diabetic. So now you have 2 oranges. So you're like, okay, I can manage this, but my hands are really full. So with an orange in each hand, you're starting to get overwhelmed. So now what if they say you have anxiety and depression because of this? So now your arms are just full of all of these burdens that you're trying to carry and you're overwhelmed. So palliative care is like a basket to hold your oranges, is what we tell people. And it's so cute and catchy. So it's not uncommon for a patient to get diagnosed with an illness and 3 more come along with it. So it can happen very fast, and palliative care is there to help and to help you navigate through and understand, like I said, your options and what your goals are.
I love that. That it's like this spoon theory of how many spoons you have to get you. I'm
Yes.
saying that to people that work for me. How many oranges are you carrying?
Yes.
I love that. All right. So frequently asked questions. Who pays for it?
Yes. So this is another big one. So at this time, it's the same as hospice care. So Medicare and Medicaid and other private insurances cover palliative care. So that's the biggest concern. I mean, in the society that we live in and the cost of living,
Mm-hmm.
of course, that's the number one question. How expensive is it? And so it is covered by your insurance. And the reason insurance pays for this is because it's not good for insurances when patients are frequently going to the hospital. Okay, so insurance says, wow, this is fantastic. This is an extra layer of support for the patient. They're still going to see their primary care provider. They're still going to see all their specialists. They're still seeking treatment. But this is an extra layer of support that this patient can call when they're in the time of need or in a crisis to maybe prevent them from an unnecessary ER trip. Because and that in itself, who wants to have to go to the emergency department because they don't know what else to do? So palliative care helps with that. With one addition to our palliative care is VA insurance, like veterans, they have their own palliative care department here locally. So I say here because it's different everywhere, but the Huntington VA and Charleston VA, they do have their own palliative department. So patients that utilize the local VA would need to utilize their palliative care. So I always just put that in there because when I say Medicare and Medicaid and most other insurances, VA is excluded only because they have a super robust program. So it's not any less than what the outpatient is offering. It's still the same great service with great benefits. May have a little bit of things different in their own program, but still a great service.
And am I right that not all hospice centers across America have this, right? Like we're very, I don't know what the word is, but lucky to have
Yeah,
this. Yeah.
we are. And even here within West Virginia, not all hospice cares have a palliative care program.
Right.
Most do, but there are some that don't. And of course, I won't touch on those that don't, but there are some counties that lack palliative care. And so what we do as our company, we say, if you live in West Virginia and there's not a palliative care in your area, we will provide that for you at least via telehealth.
Okay.
So if there is no access to palliative care in a certain county and the patient really needs palliative care, we can do that via telehealth. So that is something that we do try to make up for the lack of all hospices having palliative cares. But that is true. It's not everywhere. So
Thank you. And why use it?
this is a big one. So in my mind, everyone needs palliative care. So palliative care gives the patient a voice. You know, like I had said earlier, when you leave the doctor's offices, these offices are overwhelmed for multiple reasons. And it's not for lack of bedside manners. It's the physician has so many patients to see and not enough time to sit down and have an hour-long conversation. So why palliative care? Because we can have in-depth conversations that you are striving for. So again, we let the patient lead the conversation. So we help the patient with advanced directives off the get-go. Do you have advanced directives? Do you have a medical power of attorney? Do you have a living will? What's your code status? Do you understand what that means? So we initiate these conversations and let the patient tell us their goals, and we can help get advanced directives for them. Goal clarification is one of the biggest things that we emphasize on in palliative care, because a lot of times the patient wishes don't align with the family's wishes.
Yes.
So a patient, and maybe the patient's not super vocal that what they want isn't aligning with what their sister or daughter or whomever wants. So we help with these conversations. We figure out what do you want as the patient and what do you want as the family, and try to help educate both sides so that we can come up with a plan for them. And the bottom line just says who else might be having these conversations. And honestly, and I'm not saying this as a negative thing, but likely no one. These offices are so overwhelmed. So in quite honesty, offices are so glad to hear that their patients are signed up with palliative care.
Yeah.
And they say, oh, this is fantastic because we can go in and have these conversations with these patients, all while the patient is still seeing their family doctor. They're still seeking all treatment. They're still seeing their specialist, but we're in that home setting and we're in there for an hour or 2 hours or whatever they need to have these conversations.
Yeah, I think that's so important because we, as I said, Just Us Retirement, we try to do things from a different approach. And although we're helping you with retirement, we bring in guest speakers, we do workshops on getting those directives. And it's so often people do not want to discuss it and they wait until they have to have it.
Mm-hmm.
And so I think it's really good that you guys are opening that up, and just encouragement again for people watching this. Don't be afraid to have those conversations. It's easier on the family. It's less expensive. Everything is easier if you can do this in advance.
Absolutely. And we don't charge a fee to help you fill out your medical power of attorney or your code status. I mean, all of this is encompassed in the service that we provide. So it's very important to just go get the conversation started and ask questions. Don't feel embarrassed that you're not sure what a full code actually means, what a DNR. Like, don't feel embarrassed. Ask the questions and get a good answer so that you can prepare.
Yeah, and just as a backup on what you're saying, that's so important. You guys don't charge for that, because what happens a lot of times is it gets to the last minute and then there does have to be a court case involved. There does have to be charges involved. And it's emotionally so much more taxing on the family. If the family has to say, what would mom had wanted us to do? And if we can get people to plan early for that and say, this is how I want to be treated, it's so much easier on the family and the care receiver.
You're exactly right. And a lot of referrals that we get are from physicians saying, I want to refer my patient for these conversations.
Yes.
So
love that. All right. Hospice or palliative?
Okay. So this is a screen that kind of shows the differences.
Okay.
So hospice care is life limiting. You have to have that diagnosis of 6 months or less to live. You can surpass that, but you have to initially have that diagnosis. Okay. With palliative care, you just have to have a serious illness, COPD, CHF, cancer that you're seeking treatment for, end-stage renal disease. Hospice care is covered by insurance. And palliative care is covered by insurance. Now, it has in here may have a copay. Some palliative care programs do charge a copay, but at this time, ours is covered by insurance. Okay. For hospice care, it may be managed by the hospice care physician. This is a good one to kind of touch on a little bit longer. Just because you're on hospice services doesn't mean that you have to use our physician. Our physician is specialized in end of life. So most patients use our physician because of that. But there are some primary care providers that continue to manage their patients. So we don't completely take that away from a patient if they say, I love Dr. Jones so much and I want her to remain my physician. As long as Dr. Jones is okay with that, then that's okay with us. Some physicians say, no, I don't feel comfortable, let the hospice manage. So I just want to touch on that. And with palliative care, you're still maintained by your primary care provider and all of your specialists. Hospice care is non-curative. It means maybe you've sought treatment and there's no longer anything else they can do. And while palliative care, you're still seeking that aggressive curative treatment.
Okay.
Hospice care, you get the 5 days respite paid for every 30 days. Unfortunately, with palliative care, you can have respite, but it is at a daily rate of $3.25. So it does not come free while you're on palliative services.
Mm-hmm.
Hospice care is 24/7 on call. So it doesn't mean someone's with you 24/7, but it means you have access to someone 24/7 and you get weekly to daily follow-up visits. Palliative care, there are no after hours. So we are a Monday through Friday, 8 to 4:30, and you're seen bi-weekly to monthly. So that's huge. Okay. So hospice care, you're seeing daily to multiple times a week. Palliative care, every 2 weeks to once a month, you'll get a visit. Hospice care is a rapid response team. So that means we respond immediately. If a patient calls and says, I can't breathe, or there's something going on with mom or whoever the patient is, we respond immediately and a nurse is immediately sent out. Palliative care is not a rapid response team, meaning a nurse can't be there that same day sometimes. Mm-hmm. Sometimes it's within the week, or sometimes if it falls on a Thursday and they can't see them on Friday, we may have to direct them to their primary care provider for care. Hospice care, when a referral is sent or a patient calls in wanting hospice care, the consults are seen within 24 to 48 hours. So that's quick, okay? Palliative care, it's about a week. So we say 7 to 10 days because of the weekend, if it falls when there's a weekend that, you know, in the mix. But I always say, if in doubt, call hospice. Ask questions, see what your options are, because you're going to be seen much quicker with hospice because it's more urgent than if you're like, I'm not really sure if I'm more hospice or palliative. I'll call palliative first because it is a slower, turnaround time.
Okay.
Hospice care is a team of medical director, your nurses, your aides, your social worker, and bereavement with 24/7 availability.
Okay.
Palliative care, it's nurse practitioners, nurses, and a social worker, and limited hours of Monday through Friday, 8 to 4:30 days.
Okay.
And lastly, symptom management and comfort for hospice care. And palliative care, we do provide the symptom management, but it's in collaboration with your primary care provider and the patient goals.
Okay. All right. And then I'm going to let you read this off.
Absolutely. So this is just a little slide that gives examples. So if which patient is hospice appropriate versus palliative appropriate. So I won't read word for word on these, but I'll kind of just go through the gist of it. So say a patient has stage 4 metastatic breast cancer. It's metastasized to their brain, their lungs. The patient's not eating, not drinking. That's probably hospice. Okay. Or not probably, that for sure is hospice care. If a patient has the same diagnosis of stage 4 metastatic breast cancer, but they're actively seeking chemo and radiation, that's palliative. Because with hospice care, you cannot be seeking treatment.
Okay.
Alzheimer's disease. So not all patients with Alzheimer's and dementia automatically can have hospice care. Right. There is a scale that we use. I won't go into it because it would just confuse people, but your provider, your primary care provider or your neurologist would be able to tell you or your loved one what scale you're on, and that would determine appropriateness to either palliative or hospice care.
Okay.
Congestive heart failure, if you are a class 4, that's immediately you're appropriate for hospice.
Okay.
If you're a 1, 2, or a 3, that's palliative care. And then I'll skip down to the last one. If you have COPD with disabling, it says dyspnea, but that just means shortness of breath. and you're oxygen dependent, you can't hardly move around the house because you can't breathe, hospice.
Okay.
If you have COPD and you're on oxygen, but otherwise you're doing pretty good, palliative.
Okay. And we're already at the end of it.
Yes.
I feel like you just conquered so many false myths that are out there. I mean, there's so much. People have such a fear of hospice,
Yes.
and they shouldn't. And I think you did such a great job of explaining what's available and all the good services that are available with it.
Thank you so much. And I always just encourage people, if there was something that maybe confused you that I said, or I didn't exactly answer, or didn't go over, always feel free to contact us. We have a robust intake team and reception. So you can call our phone number, 304 768 8523. That takes you to our main intake or reception, and you can say, I have some questions about palliative care, or I have some questions about hospice, or I have questions about it all. Who should I talk to? And they will transfer you to whomever is best to answer those questions. And myself, I'm available to the public for questions. I have a mobile work cell that I'm available Monday through Friday to pick up that phone, and I have conversations with patients and answer those questions as well. And Tabitha, I can give you my information if you wanted to give that out to patients or
Absolutely.
to the community. So absolutely call us. Don't be afraid, because education is power. So if you're educated about a service, then you can take the fear out of it. So
Yeah, absolutely. And it's probably not surprising that we went a little bit longer than an hour. And we do have some questions in the chat area, but keep the questions in there. We will reach out to everyone that left. We'll get all of those questions answered. Just don't want to hold everyone up. So, Sierra, thank you so much. Really appreciate this. And I think we started a good step towards changing our community around this idea.
I sure hope so. Thank you so much for the opportunity.
All right. Thank you, guys. Everyone, have a good day. Thank you for attending this.
Bye.
Don't forget to share it with friends, have a conversation. We can all make a difference just by having simple conversations. So, thanks, guys.